Hello, welcome to our November ethics lecture hosted by the Fairbanks Center for Medical Ethics. We are so glad that you are here and joining us today. I'm Robin Axel Adams. I'm the manager at the Fairbanks Center, and we're so glad that you joined us remotely today. Just as a note, as we think about, before I go into our lecture for this month, next month, we will be working at the other end of the spectrum of life as we look at the updates on ethics and geriatrics. And so we will be live in Pettigrew if you wish to join us. We will still provide all of the great virtual options that you would like, but if you'd like to join us live in Pettigrew, we look forward to seeing you next month as we look about the issues in geriatrics. So when we were thinking about lectures for this season, as the mother-baby unit is in the process of moving from Methodist to Riley this weekend, the FCME faculty realized that there will be new ethical challenges that could develop having women in a children's hospital. So our lecture this month and then last month focused upon those issues. And so we are so excited to be able to bring another topic today that is going to pertain to mothers and babies. And while we have people that are outside of IU health systems today, we know that the topic of pregnancy termination affects many of us. And so we are glad that you're able to join us today to help us think through this topic. And so as we think about our lecture today, we all know that we have mastered Zoom, but we know that technical issues could still happen. And so we just thank you for your patience for that if something does happen. As a reminder, the webinar is being recorded and it will be available on our website, fairbankscenter.org, within the next week. The recordings are going to be eligible for continuing ed for 30 days and for continuing medical education for a whole year. And so we encourage you to send this information to your colleagues. Tomorrow, you will receive a link on the evaluation for the CME and the CE at the email address that you provided when you registered. We really encourage you to fill out the evaluation even if you do not need credit, because this does help us track our virtual attendance and it allows us to provide feedback and comments on the lecture. The Q&A box will be the place where you will answer questions today. We do not leave the chat open for any of our lectures, just so that we're not all distracted by side conversations. But at the end of the lecture, then I will be fielding those questions to Dr. Bernard once she is ready. And Dr. Bernard has no financial conflicts of interest to disclose. All right, so now let me get on to introducing you to Dr. Bernard so that she can continue to lead this great discussion. Dr. Caitlin Bernard is an obstetrician-gynecologist and a family planning specialist at IU Health and is an assistant clinical professor at IU School of Medicine. Her clinical and research work, both in the US and in Kenya, focuses on expanding access to comprehensive reproductive health, including contraception, safe abortion, miscarriages, and pregnancy care. So Dr. Bernard, thank you so much for coming and sharing your wisdom with us today.
Thank you so much for having me. I appreciate it. I'm going to share my screen here and hopefully it'll work. Can you see that?
Yes, everything is great.
Okay, perfect. Yeah, so thanks so much for having me. We're going to talk a little bit about, as she mentioned, values and ethics around pregnancy termination, particularly as we move from IU Health Methodist to IU Health Riley Hospital. And I know that this can be a difficult topic. So please, feel free to ask questions, answer honestly for their poll questions, and those are all anonymous, and also feel free to contact me at any time in the future. As she mentioned, I have no disclosures. So our objectives today are to apply IU Health values as well as medical ethical principles to the care of patients considering Can you hear me now?
Yes, I can hear you. I'm not sure if everyone else did. I lost sound for a minute though.
Okay, yeah, it said I was somehow muted. Probably an informal opportunity that this lecture provides is to just provide some introductions Obviously, obstetrics and pregnancy care is new at Riley Hospital, and abortion, also known as termination of pregnancy. I tend to use those terms interchangeably, most often for the comfort of our patients who sometimes have a great deal of difficulty with using the term abortion, is a part of obstetrics and pregnancy care. And whether, we all feel comfortable with that or not, it is the reality. There is a whole spectrum of experiences, beliefs, feelings about abortion in general, and potentially particularly about abortion being provided at Riley Hospital, given its history as a children's hospital. And we want to, be transparent about what care is being provided, validate anybody's feelings about that, and be proactive in answering any questions that arise. And our second goal is really to lay some common ground about what we are providing, why we're providing it, and what everybody's role might be in that, and ensure a culture of respect for especially each other and our patients. I'm going to include some clinical cases in my talk today. These are intended to begin to introduce some of my patients to all of you, and some of them are your patients as well, and also to think a little bit about what care is being provided, again, why we're providing that care, why we feel it is important, and to introduce these patients. So the first one is luckily not typical, is more difficult than most of the patients that we have. She was a 16-year-old nonverbal female with significant developmental delay and cerebral palsy. She actually coincidentally initially presented to the Riley ER reporting nausea and vomiting. Given her developmental delay, and there was no thoughts, I think, about pregnancy at that time, a urine pregnancy test was not performed. She did have a CT scan, which in retrospect did show fluid in the endometrial canal, but was not diagnosed as a pregnancy at that time. She was discharged home. And she did re-present to an outside hospital only once her mother noticed that she was increasing in abdominal size. And she was referred to me at 21 weeks and 2 days gestational age. And later it was confirmed that she was raped by a family member. So our first poll question is, have you or has someone close to you ever had an abortion? And I include the option of no, not that I know of, only because we know that this is particularly common, and many people may not be disclosing that to you. And we'll take a minute. Again, these are all anonymous, and feel free to answer honestly.
I'm going to give it about 10 more seconds.
Yeah, so this is really, I think, typical of probably most, groups of people that are polled, which is that the majority of people either have or know somebody close to them who has had an abortion. And this is important because it humanizes it, right? We all have been or can imagine being in a situation like this. And that's an important way for us to think about and demonstrate our compassion for patients. Similarly, when we look at, kind of what people's beliefs about, abortion legality and whether it should be legal only under certain circumstances or in all circumstances, we see that over time, 1975 to 2017 in this particular poll, that really hasn't changed. The majority of people believe that it should be legal under certain or any circumstances. And that is really important to think about. If we do believe that as a nation, as a country, then that actually needs to be carried out such that the care is able to be provided. And that's particularly difficult, of course, here in Indiana, and we'll talk a little bit more about that. I really like this slide or this kind of visual depiction because I think it helps us to start to think about the external influences and the personal and internal influences on the left, as well as our professional obligations and the circumstances of the person or the choices around having an abortion, to think about how we feel, how we consider our involvement potentially in the care of somebody having an abortion, our beliefs around whether this should be, again, legal or even provided, again, either in the institution in which we work or even by ourselves, by the care being provided by us. And these are things that I think are helpful to think about ahead of time. I think that, again, is one of our goals for this, is to introduce this concept to everyone working at Riley, such that you can begin to think about if and when you are faced with the potential need to care for these patients, how you might feel about that and what things that you might weigh to come to that decision. And again, this is potentially a process that is demonstrated in here, right? Your life stage, potential changes in terms of your obligations, personal experiences may change over time, and this is a good way to think about all of those. So our next poll question is, how comfortable are you working in a hospital where pregnancy termination is provided? Anywhere from not at all comfortable to very comfortable, or potentially not sure yet and open to influence or thinking about it a little bit more, as we are today. And again, these are all confidential, anonymous responses.
I'm going to give it about 10 more seconds again.
Great. I think, this shows what I think is true, which is that we have, a spectrum of people's levels and maybe even some people who aren't sure yet. I want to make sure that we're addressing everybody's concerns, answering all of the questions that people might have. Our goal is not necessarily to move you in your comfort level, but just to ensure that concerns are responded to. One of the things, as I mentioned, is really creating a common ground. We find those in our, institution and the organization that we work for, IU Health, and our values that have been put together by this organization. These include purpose. We work to do good in the lives of all others. Excellence, we do our best at all times and in new ways, which I always find interesting because it leaves open that door for evolution and improving the way that we do things. Compassion, we treat all people with respect, kindness, and empathy. Again, both patients and each other. And team, we count on and care for each other. And the other common ground that we as medical professionals have, and given this is a lecture on medical ethics, are those core principles of medical ethics, including non-maleficence, the duty to avoid causing harm and to minimize harm that may occur to the patient. Beneficence, the duty to maximize benefits to enhance patients' well-being. Respect for autonomy, our duty to respect a patient's right of self-governance. And justice, duty to treat patients fairly and equitably. And so I really encourage us to think about all of these values and ethics in coming to, our objectives, which are to think about how we can apply these in the care of our patients undergoing pregnancy termination. So I want to talk a little bit about what termination of pregnancy abortion care at IU Health looks like. Certainly, it's most important to understand that these cases involve a great deal of discussion, and sometimes over many sessions between the patient and maybe trusted advisors in her family community, as well as the medical team, and that can be a wide array, including obstetrician-gynecologists, high-risk OBs, and others, to determine what the best medical option for them. And please know that, in discussing with patients, they often either feel that they have no option or feel that, they are making a very difficult choice between two bad choices. And so certainly this is not taken lightly by anyone. It's also important to understand that abortion can be life-saving. There are many situations in which pregnancies are quite complex. We would like to think, of course, that every pregnancy is healthy and happy and every baby is healthy and happy, but obviously you guys work at a children's hospital, that that's not necessarily true. And in many cases, abortion can be the best medical option for patients. It's important, again, in thinking about laying that common ground, that we cannot allow our feelings, our religious beliefs to interfere with our respect for each other or for our patients, and that we do respect everyone's right to conscientious objection, but that this cannot create a barrier to patient care at IU Health. So our next poll question is, how knowledgeable are you about the laws and policies around abortion in your state and in your institution? And this is probably mostly an answer for me, so I kind of have an idea of maybe where we're starting from. And of course, we'll talk about it a little bit.
About 10 more seconds. Having really good participation in these.
Great. Yeah, I think that's helpful. That a good percentage of people are at least somewhat knowledgeable. So hopefully I can increase that knowledge level a little bit today. And certainly, if there's any questions later on, please don't hesitate to reach out to me. So in terms of Indiana abortion laws, if anybody here pays attention to the legislative sessions every spring, you may know that these evolve annually. And as those laws are passed and then work their way through the judicial process, many laws may have been passed but are not actually in effect. And so these are the ones that are currently affecting the care that we provide, clinically. They're in effect and impact our care of patients. So in terms of gestational ages, so the upper limit in Indiana for providing abortion is 21 weeks and 6 days. This is based on last menstrual period. Some people have heard of the term 20-week ban, but that implies counting from post-fertilization, whereas in obstetrics, we count from last menstrual period. And so that actually is 22 weeks. And that is based on their determination of viability. That is a moving target in obstetrics, as anybody who, I think people in the NICU and Riley certainly know that that is a moving target, but that is what has been decided here in Indiana. In terms of gestational age and where a procedure can be performed in the second trimester or 14 weeks and above, this must be performed in a hospital or an ambulatory surgical center. In Indiana, there are no ambulatory surgical centers that provide this care. And so any procedure being performed in the second trimester must be in a hospital. And to be quite honest, that is primarily in referral hospitals such as IU Health systems. First trimester abortions can be performed in outpatient clinical settings, and there are multiple clinics in the state providing that care, though of course mostly concentrated in Indianapolis. State mandated counseling, meaning that they have a list of things that we must tell patients, and informed consent documents must be signed, and an ultrasound performed prior to the waiting period, and the mandated waiting period is 18 hours. This is for minors less than 18 years of age. This is required to be co-signed by a parent, or they may petition a court or judge to receive abortion care without notifying their parent. All pregnancy terminations are sent to the state health department. And most importantly, in terms of insurance coverage or accessibility, Indiana Medicaid only covers in cases of life-threatening pregnancy, rape, or incest. In terms of IU health policy for pregnancy terminations, you can obviously search it in our database of health policies. It's called Pregnancy Terminations. We are allowed to perform pregnancy terminations for medical indications as determined by the patient and the patient's physician in compliance with state and federal laws. And so when we say in compliance with state and federal laws, that ensures a continual process between our legal team and ourselves to ensure that we are providing this care as required by the state. In terms of indications, what rises to the level of a medical indication, our policy goes on to clarify that these include but are not limited to medical or obstetrical conditions for which the continuation of the pregnancy would jeopardize the health or increase the risk of maternal death. And those are what we often term, medical indications or maternal medical indications. This also can include psychological conditions in which continuation of the pregnancy would jeopardize the patient's mental health. Also fetal anomalies or karyotype abnormalities, also known as fetal indications. And also importantly, again, as our role as a referral hospital, procedures in progress that cannot be completed. And so what that means, and we'll talk a little bit about a case potentially, is if a procedure was being performed in an outpatient clinic or at another facility, and there was a medical emergency for that patient and they needed to be transferred to the hospital. So in terms of examples of what types of medical maternal indications this might include, these sometimes can be categorized into life-threatening, meaning that there is a significantly increased risk of death related to that condition. This is often, again, diagnosed or counseled for the patient in conjunction with our maternal fetal medicine, our high-risk obstetricians, as well as, potentially their other medical specialists, cardiologists, nephrologists, et cetera. Many of these conditions are related to the cardiovascular system, which we know is particularly stressed during a pregnancy, and the risks of cardiac events increase significantly, even for normal healthy people, but then significantly more so for women with things like pulmonary hypertension, certain types of cardiac syndromes, and heart failure. And then health threatening, meaning that we know that this can cause long-term permanent damage to the patient if they were to continue the pregnancy. This includes things like renal failure, venous thromboembolism, DVT and pulmonary embolism, which significantly increase in terms of risk during a pregnancy, as well as cancer, for which care may be delayed because of a pregnancy. And also psychiatric conditions. So for example, in cases where suicide would be a significant risk for the patient to continue the pregnancy. In terms of fetal conditions, these can often be separated into lethal fetal anomalies. Again, this is a challenging, similar to viability, a challenging determination to make prenatally. But is often considered to include things like anencephaly, bilateral renal agenesis, where the kidneys are not developed, certain types of skeletal dysplasias, where the chest cavity is so small that the lungs will not be able to develop, and certain types of trisomies or genetic abnormalities. And then other abnormalities, other fetal anomalies that would be included in a counseling session in terms of options, prognosis for this, this pregnancy, this potential baby. Include things like hypoplastic left heart syndrome, hydrocephalus, and genetic abnormalities like Tay-Sachs disease or trisomy 21. Things that are not considered induced abortion are other pregnancy complications that arise and are considered to be abnormal pregnancies in and of themselves. So this includes, for example, pre-viable, meaning less than 22 weeks, preterm, premature rupture of membranes, in which the woman has broken her water, and there is significantly increased risk to her in terms of both infection and bleeding, as well as very poor prognosis for the fetus, for the baby, as well as pre-viable advanced cervical dilation. These are considered incomplete or inevitable abortions, spontaneous abortions, and patients are counseled, as always, about what options they have, and the option to end the pregnancy, to manage the miscarriage or pregnancy loss, to avoid the risks of continuing the pregnancy. Molar pregnancies are a really challenging type of pregnancy complication, luckily relatively rare, but sometimes they include a fetus, either in a partial molar pregnancy or even in a twin pregnancy with a fetus as well as a molar pregnancy. And these are particularly dangerous as they're actually precancerous and cause a significant dysfunction during a pregnancy. As well as we are seeing a lot more cesarean scar pregnancies that are considered ectopic as they're implanted into the scar where somebody has had a cesarean section in their uterus, and other types of ectopic pregnancies that may sometimes have cardiac activity detected on ultrasound. So all of the patients in all of these clinical scenarios that we already talked about go through an extensive counseling sessions. Again, as I mentioned, over time sometimes, and with multiple specialists often. They receive lots of information from their own medical specialists, OB, MFM, myself, as well as potentially NICU or PED specialists about what pregnancy continuation would look like, what the prognosis for this pregnancy would be. We also have a long discussion about risks and benefits. In general, even in a normal pregnancy with an otherwise healthy person, you are significantly more likely to die from continuing a pregnancy than ending a pregnancy. And particularly the conversation that I have with patients is around potential other risk factors that they have for serious pregnancy complications, as well as the viability or the lethality of the fetal diagnosis in terms of what the outcome of the pregnancy would be for them. And weighing those risks and benefits is particularly challenging, but very important, both for the patient and for her family. All patients are given the option or counseled about perinatal hospice. Obviously, this is important. Number one, it's required by the state for us to offer this information to them, but also to, again, look at what continuation of pregnancy would look like and what that care that they could receive would be. All patients are provided bereavement support. We have a fantastic perinatal bereavement program that I know will be obviously moving with us to Riley, and are supported in their love and creation of memories for the pregnancy that they have had. Many people face stigma when we look at, questions of long-term mental health, psychological effects of abortion on women who experience them. Most of that ill effect or the challenges that they face are related to stigma and how they might be able to explain their pregnancy termination to family, friends, how they're able to deal with what many have experienced is a lifelong feeling that they would never have an abortion. They don't necessarily even think that it would be a good choice for most people, but yet, of course, they're finding themselves in this situation. And then we talk a little bit about cost, unfortunately, for the lack of insurance coverage for most people. So what does this look like? Particularly many patients present in the second trimester, either as their medical condition worsens and they find that the balance of those risks and benefits is leaning towards increased risk for them, or that is when they're diagnosed with fetal indications. Particularly with the anatomy ultrasound that occurs around 18 to 20 weeks, or genetic testing that often doesn't occur until even after that. And so we talk about their options for induction of labor or dilation and evacuation. So medical induction of labor can be challenging in terms of timing. So hard to know how long a labor might take. They are awake during that entire process, but do receive pain control. When we talk about procedural risks, we do know that with induction of labor, there is an increased risk for bleeding and potential need for D&C for retained placenta after delivery of the fetus. Dilation and evacuation can be a 1 or 2 day procedure, depending on gestational age, how far along they are in the pregnancy, and they are asleep or under anesthesia during the procedure itself. Most importantly, I think for patients, both of these are very safe options. There are no significant risk to future pregnancies, barring very rare complications that can occur in either procedure. And both provide the option for the diagnostic testing that may be recommended by genetic counseling, medical genetics, or our MFM colleagues. And both provide patients the opportunity for bereavement, for memories, and for closure. When we look at which is better for patients, we find that really the procedure that they have chosen, that they have made the decision to have, is the best option for them. Again, there are also certain medical conditions, pregnancy complications that may indicate one versus the other. One thing that I think is important when, particularly when we talk to patients, but also when we talk to each other, is understanding that these procedures are indicated. They are medically indicated and not considered to be elective. The term elective termination of pregnancy is very commonly used and is incredibly hurtful to patients, having seen and heard their reactions to that. As I said before, many patients do not feel that they're making a choice, or that they have no real choice in this, and certainly that they're electing to do something, that this is a situation that they never thought that they would find themselves in, that that this choice is being forced upon them in many ways. And so it's important to think about that, both in the way that we talk to patients and also in the way that we perceive whether this procedure should occur, or the morality around the procedure. Our next poll question is, have you ever heard a colleague in a professional setting talk in a derogatory manner about a person or a patient who has had or is having an abortion? And I think, again, I would love to see, honesty and that this can potentially open up a discussion about how we talk about this topic and how we can improve our respect for each other.
10 more seconds.
Yeah, interesting. I don't know what to make of that. I think I'm happy to see that, at least half of people have not heard that. And so I appreciate that. But certainly maybe we have some room for improvement as well. So that brings me to the topic of conscientious objection, which is not necessarily particular to, the way that people talk about other people, but is an important part of this care, and ensuring that we're respecting each other. So the IU Health policy is titled Staff Requests Involving Cultural, Ethical, or Religious Concerns. Again, can be searched and reviewed, for your own knowledge. In it, it provides an opportunity to refuse to provide a legal and professionally accepted good or service that falls within one's scope of competent practice. And so that really can be, kind of no matter what your role is, whether that's physician, nurse, or any other role in the hospital. The important part, I think, is that this must truly be based on cultural values, ethics, or religious beliefs, and not for any other reason. For example, not, wanting to be involved in a procedure that you might not like or think is the right type of procedure. However, it is specific to a particular procedure, meaning that you cannot have a conscientious objection to care for a particular type of patient or for a particular patient diagnosis or behavior that they're having. And I think that this is very important, again, in ensuring respect for patients in all of the different types of patients that we see and all of the different types of situations that we see. It's also important to note that this cannot prevent patients from receiving care, that there must be alternate care reasonably available. And this is something that we at IU Health Methodist have worked diligently to be able to provide. There's constant communication between physicians, nurses, anesthesia, and everybody on the labor and delivery unit to understand how we can ensure respect for staff members' conscientious objection while being able to provide this care reasonably for our patients. And I haven't noted, I think maybe it would be helpful to do so, that the vast majority of this care is provided on labor and delivery, both including inductions of labor and surgical procedures. However, there are instances in which this care must be provided in the main operating room. The instances in which that is most often to occur regards emergencies that may happen, where that would be the best and safest place for them to occur, for the procedure to be completed, or in cases where patients are significantly medically complicated and anesthesia needs, the equipment and the personnel that occur in the main operating room to be able to provide that care safely. So the last part is just to go through a couple more clinical cases. And my ask is to ask yourself, not to answer, although happy to hear more questions or responses in the Q&A or discussion afterwards. But really to ask yourself what I think of as a two-part, but also potentially separate questions, which is, would you personally feel comfortable participating in this patient's care? And yes or no, regardless, do you think this is care that we should be providing at IU Health Riley Hospital? And I think this will help to guide each other in thinking and interacting as this care does in fact move to IU Health Riley Hospital. So this is somewhat similar, or was brought up in last month's conference with Dr. Rouse from Maternal Fetal Medicine about very complex pregnant patients. So similar to her case, a 28-year-old who at 19 weeks was finding herself in peripartum cardiomyopathy, had been diagnosed earlier on with what was a relatively mild case, was counseled at that time about the risks of continuation of the pregnancy and did want to continue the pregnancy, wanted to have a baby, but at 19 weeks became significantly worse, including symptomatic, and was found to have heart failure with an ejection fraction of 23%, significantly worse than earlier in her pregnancy. And at this point, this condition puts her at high risk of dying during this pregnancy. So similarly to the case presented last time, this patient would be counseled about her significant risk of dying during pregnancy, and again put in that incredibly difficult decision to weigh her own life against the potential life of her fetus or baby. And again, nobody, what I tell patients is nobody can make the decision for you. No two people will make the same decision in this scenario. In the case that was presented last time, she decided to continue the pregnancy and did in fact die in the postpartum period. And the effects that that can have of losing, a mother at a young age for her other children, losing a partner, losing your own life can never be dismissed and can never be decided for somebody else. So in this type of a case, we would offer her a pregnancy termination at IU Health. This is a case that is unfortunately too common, certainly probably people that you see and care for at Riley. A 30-year-old with a prior baby who is affected by a genetic disease. And that genetic disease resulted for that child in severe disability, need for multiple surgeries and long-term care at Riley. She is now 14 weeks pregnant, with all of the difficulty and anxiety that must bring for her to be pregnant again. She underwent early genetic testing, which is an option here with our maternal fetal medicine specialists, and was diagnosed with a pregnancy affected by the same disease. And again, nobody can imagine being in that situation, watching your child suffer, and thinking about or knowing that the same could happen for your next pregnancy. And the last one speaks to that sometimes challenging issue, which is that we may not have offered this procedure at the beginning, but as a referral hospital are now charged with the providing life-saving treatments. So a 21-year-old was undergoing an abortion at 12 weeks at an outside clinic. Her history was complicated by 2 prior sections and significant anemia to begin with. And when she began having significant bleeding at the clinic, the procedure was unable to be completed, and she would be transferred potentially to Riley Hospital for emergency management. And again, when we come back to that idea of abortion being life-saving, certainly any procedures that we would perform in this scenario would be life-saving for her, and the care that she would need would be emergent. It's important to also note that in cases that are emergencies, that the conscientious objection policies can sometimes be difficult to carry out, in that the care needs to be able to be provided. And so any conscientious objection that someone may have about abortions could not be an impediment to the emergency care of a patient. And so thinking back to our objectives, this is kind of my interpretation of thinking how we can apply IU Health values and our core medical ethics to this care. So to provide termination of pregnancy care with the purpose to do good in our patients' lives, the excellence to provide the highest quality medical care, the compassion to do so respectfully, and to do so as a team. And to provide termination of pregnancy care that maximizes the patient's well-being, minimizes the harm to her, ensures their autonomy, and is provided equitably. And then that last objective, as I mentioned, is really for you to think about and provide any ideas that you might have for areas for improvement in the care of patients considering or undergoing termination of pregnancy at Riley Hospital. And I'll leave that to our question and answer, and maybe follow up if anybody wants to contact me in the future. So I appreciate your attention to this important topic today, and I would love to hear from anybody who wants to talk more about it.
Thank you, Dr. Bernard, for helping us to kind of understand. It's been a long time since we've had a topic at our lecture series for the termination of pregnancy, so we appreciate you doing this one today. Questions are coming in. So can you talk about, you mentioned memories as an option for bereavement and counseling postpartum procedures. Can you explain that a little bit further? Can you talk about that a little bit?
Yeah, so and everybody, again, you know, patients will want different things. So we talk about maybe what they might want. They may bring to us things that they want, and we will do our utmost to make those happen for them. Certainly, things like heartbeat recording is an option prenatally. In fact, you know, they can get a recording device at a Build-A-Bear and have it put into a bear or a stuffed animal so that they can have for the long term. We do footprints and handprints, and again, that can be, you know, regardless of D&E or induction of labor, depending on gestational age, obviously. The bereavement team will make molds of hand and footprints. They'll put together a box of memories that patients can put, you know, photos from ultrasound or anything else that they may have together in that.
Thanks. I want to just mention, since Dr. Rouse just turned her picture on, that she provided our lecture last month and is here to provide answers for questions as well. So Dr. Rouse, I'm not going to automatically ask you both of the questions, but if you would like to jump in, please do. Does that sound fair? Excellent.
Thank you.
Yeah. I think that this is just sort of going to be able to be a factual answer, but so adolescents have a right to confidential reproductive care, but the state overrides parental care for termination of, or state requires parental consent for termination of pregnancy. This is a direct or deliberate override with a question mark. So we don't want to go into the political realm, but sort of a factual is the yes, the state does require consent.
Yes, yeah, absolutely. So they do override. And, you know, again, some of that comes into a little bit of federal versus state laws and interpretation of laws and rules and rights. And, you know, Indiana has overridden that kind of medical principle that we have and some of the federal laws around that. But many states have done so and continue to do so. And this is not something that is likely to change. You know, there has not been any strong argument or legal case that has been brought that gives us the opportunity to overturn this. And so at this point, that is what is required. Certainly, there is a strong support network here in Indiana for providing judicial bypass for adolescents who do seek this care. Certainly, we do have that from time to time and are happy to connect patients with those resources at any time.
We have a couple of questions about sort of the mixing of the pregnant women with women who are about to deliver and women who are about to have a termination of pregnancy. So the first question around that is, are there potential issues identified with mixing? Sorry, when someone else writes a question, my questions go differently. Are there potential issues identified with mixing women who have had a pregnancy termination with women who are expecting to deliver a baby? And so how are those issues being mitigated?
Yeah, I think that's a really good question. In many institutions, this care is not performed on labor and delivery, and it's felt, you know, that would be difficult for patients to be on labor and delivery. You know, certainly, I haven't spent a lot of time at Riley yet, but at Methodist, most of the pictures on the walls are, you know, families, happy, healthy babies. And that, yeah, can be definitely emotionally challenging for my patients. I think the way that I explain it is that we know that this is where you will get the best medical care. Labor and delivery nurses are uniquely qualified to provide the best peripartum care, and that includes D&E or induction of labor as well. And it also provides, a somewhat comforting and safer space than, for example, the main operating room. If you've ever been to, for example, the Methodist main operating room waiting area with the, thin curtains that everybody can hear through. And also, again, for the bereavement needs, the loss of a full term, fetal demise or a newborn baby is very similar for most people to the loss of a pregnancy earlier on. And so again, they are uniquely qualified to provide that hands-on bereavement support for them.
Will all abortions performed at IU Health be performed due to medical risk to the mother?
So our IU Health policy includes either maternal or fetal indications. And so that could include risk to the mother, as you mentioned, or fetal abnormalities that are diagnosed prenatally.
Your last example that you gave of your case was a case of an emergency case with a woman being brought into the hospital. With the emergency case, like your last case example, would that person end up in the OR or in labor and delivery?
Yeah, that's a good question. I think a little bit has to do with logistics as well as the severity of her condition. So for example, if she's receiving massive transfusion, probably the main operating room would be the best, quickest avenue from the emergency room. But I can also imagine a case where she comes in relatively stable and there are no available, operating rooms in the main OR, or the quickest available operating room would be on labor and delivery. And so I can imagine a situation in which we may feel that that would be the best option for her. I don't know if Dr. Rouse can answer a little bit more about logistics on that side.
Logistically, I think that the vast majority of any of this type of case would be performed on labor and delivery. We have 4 operating rooms, one of which is a bit larger and set up for eventually fetal surgery, but also non-obstetric surgical cases. And so, all that to say, it has the capability to handle a lot of people in the case of a significant emergency. And so I do not foresee the Riley Main OR being a site of provision of care for these cases, except for in incredibly rare circumstances. I think that potentially still the Methodist main OR, depending on the gestational age and the clinical scenario, certainly in, obstetric and gynecologic cases may still be performed there, particularly after, for example, cases of major trauma and things like that. We will also have medically complicated patients over at Methodist who require CD or neuro ICU care, or for example, are on ECMO. And so if any of those patients ended up needing a pregnancy termination procedure, that would likely be happening in the Methodist main OR, since there will be no more labor and delivery ORs over there.
I think this is a legal question, so we can see whether you can answer or not. But what do you do with patients who've had an abortion but do not want to cremate or enter the product of conception, and they just want to approach the abortion as any other medical procedure?
Yeah, so in Indiana, they're at less than 20 weeks gestation. They have the option for hospital, what we call hospital disposition of the remains. The hospital takes care of those remains by cremation, as is required by Indiana state law, along with, for example, products of conception from miscarriages and things like that. Above 20 weeks, patients are required to contract with a funeral home to take care of the remains. My understanding in very rare circumstances is when they do not follow through with the requirements, for example, to contract with the funeral home, that the hospital is able to make arrangements for those remains through a funeral home that they have contracted with.
Do we know sort of the latest understanding in the medical field about the feelings of the fetus who is being aborted? If it is a painful death, or what kind of medications are given so that the fetus and the feelings of the fetus is feeling?
Yeah, so the best medical evidence that we have, and this is collected over years of research, and is backed by, for example, fetal surgeons who perform surgery for example, neural tube defects on fetuses in utero, is that there is no capability for pain at less than at least 24 weeks gestational age. So certainly well within the limits that we're providing dilation and evacuation here at IU Health. This is related to the way that the neurologic system develops between the brain and the spinal cord. And so there may be movement, things like reflexes, but there is not the sensation of pain in our brain that we consider to be pain. There has been significant debate about this, but when the best medical evidence that we have is evaluated and the best medical experts related to, particularly, as I mentioned, pediatric or fetal surgery, neurologists have all agreed that this is the best evidence that we have.
All right, security. Has there been a need to has there been the talk about increasing security to ensure the safety of patients and physicians, since Riley is now doing pregnancy terminations? I know that won't happen until in a week or so, but just didn't know if there's the talk yet about decisions with security.
I have not been part of those discussions, if there has been. I certainly have not experienced any security issues at the hospitals. So, for example, I have never experienced protesters at any of our hospitals. I have never experienced threats at my workplace. I have received personal threats to my family. So it might be something to consider.
Can you talk a little bit about the counseling? How can we do better at ensuring the counseling happens for our patients? We've had a patient that has asked to hold her baby after a D&E, which is a difficult situation to navigate. So what kind of preparing counseling do they get?
Yeah, we definitely, I think, part of it can be, there's actually been studies, evidence to say that most of what we say to patients in a crisis is not heard, right? So I could counsel somebody for an hour about the difference between induction of labor and D&E, and what she hears from that is actually quite little. So I think that is on us, as you mentioned, to improve that counseling, or to try again, or to continue the process of counseling throughout. I think the decision for D&E or induction of labor is very challenging for patients, and often has to be made in a very short amount of time, and that there can be significant I don't know what the word is, back and forth, where she, for some reasons, would choose a D&E, and for other reasons would choose an induction of labor, and that conflict is not always resolved by the time she has her procedure. And so, I talk to patients extensively in those discussions about that a D&E, a fetus is not usually intact after a D&E, and they may not want to see or hold their baby. But we also have patients who would prefer to hold, quite literally a bucket of fetal parts than hold nothing at all. And so we need to, as a team, navigate those, what they're feeling, sometimes on a minute by minute basis, and respond to it again with compassion and respect, and make decisions with them. I will routinely offer patients, if they chose or had to undergo a D&E for other reasons, if they want to see their baby's feet. And that is an option that they would have, or any part that they feel comfortable with. The things that we think we would feel comfortable with are not necessarily those that patients would feel comfortable with, and you may be surprised and just have to navigate that.
There are some really great questions that have come in. And so we know that Dr. Bernard, you have said that you would be willing to take those and respond back. So people who, and I think everyone here has answered with their name. And so we'll get those to you. So thank you. Thank you for answering some tough questions. Thank you for helping us to think about tough topics. And we appreciate your care and consideration and what you provide for our patients. So best of luck on the move this weekend.
Thank you.
All right, we'll see everybody next month.